presentation. Starting the recording. Our very first presenter today that I'd like to welcome, some of you may not have met her yet, but when you get a chance, she's in the Middletown office, she's in the Leprechaun office, I'm sure she's popped in Little Britain, and sometimes you'll find her at the call center. So Katie, take it away.
Thank you so much, Allison. Hi, everybody. My name is Katie Bannock. I'm the Director of Clinical Operations here. I started about a month ago, so if we have not met and you see me around, please feel free to say hi. So my presentation for today will be on understanding diagnosis and presentation for psychosis. Can everybody hear me okay, first of all? I think we have one. Let's see. We have somebody. Everybody can mute their mics.
If you're not muted, please mute yourself.
That'd be great. Okay, but you guys can hear me. Is that right?
Yes.
Okay, awesome. Let me share my slides and we can get started. Okay. All right. So let's see. Our objectives for my portion of the training will be to understand the basic symptoms of psychosis, as well as to learn practical engagement strategies. As I get to know the agency, I would love to know like what type of trainings and what is relevant and what is needed for you, what type of support or guidance you would like. So this is kind of where we landed for today. So what is psychosis? An umbrella term that is used to describe a group of symptoms that affect the mind and cause people to lose touch with reality. It can be a symptom of several medical and mental conditions, including schizophrenia spectrum, trauma and stressor-related disorders, mood disorders, postpartum. It can also be substance or medication induced. So it's not what I want to kind of get at, what I want you all to get out of this training is kind of like opening your mind to what psychosis can be and look like. So like I said, psychosis is an umbrella term. Underneath that umbrella, there's different types: delusions, hallucinations, disorganized thinking, and negative symptoms. So if someone is experiencing psychosis, it could be any one of these. It also does not have to be all of them. It could just be one. It could be multiple. So just to kind of give you some terminology. So a delusion is a false belief that is strongly held despite clear and contradictory evidence or logic and is not typically shared by others in the same cultural context. So some examples of delusions, again, these are thoughts. So a belief that your thoughts are being transmitted to others, believing that you have exceptional talent or power, or that you are, kind of like almighty, you are a god, believing that you are being harassed or targeted, maybe more of a paranoid delusion, and believing that a neutral event is sending you a message, which would be more of a delusion of reference. I guess it's kind of, I probably should have started with this, but my background is in adult homeless services, supportive housing and community mental health. And so these are examples of things that I've seen and worked with. So I'm kind of giving you more of the context than without like too much of the terminology. Anyway, I'll keep moving along. Okay, so the next type of psychosis is hallucination. Hallucination is a sensory experience in which a person perceives sensations that do not exist in the external environment. So examples of this would be hearing footsteps or whispering, seeing shadows, smelling smoke or perfume, feeling insects crawling over your skin or tasting blood in your mouth. Hallucinations can occur in all 5 senses. And again, they're different from delusions. Delusions are the beliefs and hallucinations are the sensory experiences. Next, we have disorganized thinking. So incoherent or illogical speech, behavior, or presentation. This might look like somebody answering a question in a way that doesn't make any sense to the other person. It might look like someone talking about things that seem unrelated to each other, but they're talking about them in a way that almost as if it's obvious how they are related. It might look like someone wearing clothing that doesn't fit the weather, or not responding or reacting to their environment. An example of, so you might see someone wearing a winter jacket in the summer or having a conversation and feeling really confused, like really not really being sure how this person is connecting these two unrelated things to each other. And then an example of not responding or reacting to your environment. Someone had a person die in their house and they didn't notice for several weeks. And that I kind of speaks to the level of disorganized thinking, that it did not kind of process the way that someone who isn't experiencing disorganized thinking would have reacted. Lastly, we have negative symptoms. Negative symptoms are a reduction or loss of normal functions. So these might look like flattened emotion or flat affect, difficulty in thinking or coming up with ideas, which is an example of a poverty of thought, when someone just cannot, there isn't any creation of thought, or like a severe reduction of it, a lack of motivation, social withdrawal, and inability to feel pleasure. So now we get into the key engagement skills when working with someone who may be experiencing psychosis. The first one I have is to connect to the feeling. Focus on the feeling rather than the belief. I find that sometimes people are very afraid of like agreeing with the person, but there's a lot of gray. There's a lot of room between saying, yes, I believe you, and no, you're wrong. What you're saying doesn't make sense. There's a lot of room in there that we can approach the person. So you don't need to agree with their reality, but if you are genuinely reflective of how they're feeling about their reality, it provides some space for a safe place, for connection, for trust to grow, which is ultimately, I think, like the biggest, most useful part of like the relationship of the intervention is the trust. The next one I have is approach with curiosity and an open mind. So try not to make assumptions or be dismissive. Take time to listen and understand their experience if they are willing to share with you. Showing empathy and respect can help build trust and reduce anxiety. So this speaks to, I guess what I want everyone to think about is, if you are not sure, if you are engaging with somebody and what they're saying is really, really unbelievable, I want you to remember that unbelievable things happen all the time. And, so sometimes we are working with somebody who's incredibly vulnerable and just had like the worst things happen in a row. And then they're coming to you and telling you. And if it's so unbelievable, we might be thinking, is this person not, experiencing reality the same way that I am? I really do want you to be curious first, unless we know, and you know what I mean, like that we know this person and this is something that's been established that they experience. But if it's like an initial engagement, and even then, like unbelievable things happen all the time. So I like to keep open the possibility that, I'm going to be really curious about what you're saying. I'm going to listen to what you have to say with an open mind, because I don't want to be dismissive. I don't want to say, oh, that's just not true. Let's move on. You know what I mean? The next one is avoid challenging or pushing. So, specifically with delusions, they are fixed and illogical. So, evidence or logic is not helpful and will just most likely upset the person. Delusions are, by definition, like not going to react to logic or evidence. In fact, it will maybe just make things worse. So additionally, if someone does not believe that so when I wanted to add this point about medication, that if someone does not believe that they are experiencing psychosis, giving them the impression that you like know better than them and that they should just take their medication is also not going to be effective, because they don't think that they have psychosis. So an antipsychotic is kind of a random suggestion, not something that's going to be helpful. So again, back to building trust is like, in my experience, the biggest intervention that we can have with somebody, the most effective. The next one is to use clear and simple communication. So if someone may appear internally preoccupied, and you can sometimes tell, they might appear to be, kind of just very preoccupied with something going on that you can't see. Just to be cognizant that in addition to your voice, there could be other things that they are paying attention to or hearing or taking their attention away. So if you are working with somebody who is currently internally preoccupied, to keep things really short and simple, um, avoid kind of being lengthy and complicated, because it might be really, really hard for them to get all of that information in addition to whatever they're experiencing internally. And my last tip is to find something shared to build trust on. So I want to always encourage everybody to be very creative and very open-minded with how you can align with someone's concerns, motivations, or values to work together in a way that is reality-based and effective for them. This may not look like the initial goal or the primary goal that maybe other people really want for this person. But it does, we have to start somewhere. It has to be, you know what I mean? If we want to make progress, we got to work towards the same goal. So I do want to encourage everybody to be open-minded with aligning with people's goals. All right, so my first scenario to kind of put some life into these tips is a 53-year-old man lives alone and believes that people in his building are breaking into his apartment and poisoning his food. He orders takeout, but won't touch anything once it goes into his fridge. Because of his financial situation, he runs out of money before the end of the month and doesn't eat until his next check. He starts to lose weight from restricting his food intake. So in this scenario, the things that I took to kind of apply to it are connecting with the feeling. So I might say something along the lines of, that must be very unsettling to have someone violating your privacy. Think about, this man really truly believes that someone is breaking into his house and poisoning his food. And, to have that be happening with you has got to be so scary. So I'm going to approach this reflecting back to him that feeling. I imagine I would feel very scared. Approaching with curiosity. So I'm going to ask, have you ever seen this person? Have you ever caught them in the act? Like, has your door ever been left open? Like, how is it that you know that they're coming in? Do you have any reason to believe someone would want to poison you? Or do you have enemies in the building? Like, can we kind of look through this to see, again, I don't want to be dismissive. Unbelievable things happen all the time. You know what I mean? So I don't know what this person's relationship is with his neighbors. And until I know for certain that it is something that is delusional, I do want to be open to the fact that maybe something terrible is going on and he really is telling me the truth. You know what I mean? Not that it's a lie, but that this is reality based. The next thing is finding something shared. So this particular man, he was not interested in seeing a psychiatrist. He was like, I don't understand why, my mental health is fine. I am being poisoned though, so I'm worried about that. So he did not, see eye to eye with his treatment team that wanted him to see a psychiatrist because he didn't agree that he was experiencing psychosis. What we could agree on, he was worried about his weight loss. He was losing weight from not eating. And so he was willing to see a general practitioner, which was a wonderful step forward. So that's where I would go with this particular scenario using these tips. Obviously, none of this is like a fast process. It takes time and patience and empathy. The next scenario is a 42-year-old woman is discharged from the hospital after she was found walking on the side of the highway. Her hair is matted to her head and she's mumbling incoherently. She's been prescribed antipsychotic medication, but is choosing to stop taking it as she feels she doesn't need them. So when you meet her, we would connect to the feeling here, which, she's walking on the highway in winter, confused. That must have been really scary. I'm really glad that you're safe. I'm really glad that you're here. approaching with curiosity, asking her something like, do you know how you came to be walking on the highway? Do you know why you were in the hospital? Or did anybody explain to you kind of how you got to the hospital? From her perspective, like what does she know and what does she remember, to get an idea of like, can I engage her? Is she willing to share with me where she's at? And then the next one of finding something shared. So after not taking medication, she began to experience really terrifying hallucinations again. She felt embarrassed and scared. And so whenever you'd ask her, hey, are you okay? She denied. She was like, no, no, I'm fine. I'm fine. But you maintain a non-judgmental and caring stance. Eventually, she does begin to tell you about her experience. So here, the shared thing is that what she's experiencing is scary, and she didn't like it. And so when you become like a safe, non-judgmental person, we can bond over that we both don't want her to be scared and then move forward towards treatment. And in this case, she did agree to exploring medication management, which was very helpful for her. I do want to talk about misunderstandings about psychosis really quickly because I think it's very important. I think there's a lot of stigma around it. So psychosis does not make someone more violent or dangerous than someone without psychosis. The truth is that the majority of people with psychosis are not violent and they're far more likely to be victims of violence than to be perpetrators. For the small portion of people who may use violence, it's important that other risk factors are considered and are more likely to be related, such as a history of violence or previous violent behavior. Psychosis is not related to psychopathy. Those are two different things. Psychopathy is the lack of or inability to experience empathy. These are separate conditions, not related at all. Similarly to having multiple personalities, psychosis, oops, let's see. Okay, sorry. Psychosis and dissociative identity disorder are also completely separate. When someone is responding, say that they are kind of seen as talking to themselves, it's not that they are necessarily talking to another part of themselves, rather that they are responding to something that they're experiencing internally that we aren't, that's not like a shared experience. Psychosis does not mean that someone will look disheveled. There is not necessarily a person who looks disheveled may or may not be experiencing psychosis. A person that appears neatly dressed may or may not be experiencing psychosis. It does not discriminate or necessarily have anything to do with external appearance. So I want to make sure that everybody knows that that's not like a direct correlation. And then lastly, it's not a one size fits all. So there are varying factors such as the frequency, the duration, the severity. And when we think about hallucinations or like auditory hallucinations, the volume, if we think about visual hallucinations, the vividness of the hallucination, that all varies. And so for someone, it might ebb and flow. For someone, it might be constant. For someone, it might never happen. And then around a certain event or with a medication, it might start. So it's different for each person. The other point that I just wanted to make about not being one size fits all is that it's based on each person's experience. So, like how much it impacts somebody is really like specific to them. Okay. I just wanted to share these resources. They are really, really wonderful for guiding conversations with people who experience psychosis with a cared person, either that's a case manager or a safe person that they receive services from. The Hearing Voices Network is a website. They have on the left here, this is a handout that they have for strategies for coping with distressing voices. And it's like 100 different things that people can do that are hearing voices in a way to like relax, calm down, to cope with it. And then on the right, they have a newsletter here for strategies for coping with hearing voices, they are written by people who experience voices. In this case, they refer to it as hearing voices. And so it's very, I don't know, I really like it. I appreciate it. As someone who does not hear voices, it has been very helpful for me to use the language and better understand what someone might be experiencing. So those are really good resources for people that hear voices. And then this is an interview. It's a questionnaire that's designed for someone who hears voices. And as a provider in supporting someone who was experiencing auditory hallucinations and visual hallucinations, I didn't have a quarter of the language that this questionnaire provided me with. Just asking questions of things that I wouldn't even think to ask, such as where are the voices coming from? Where are they located? Are they coming from within your head, between your ears, somewhere else outside of your body? Just the level of understanding that I could get from like using this questionnaire was incredibly helpful in building a relationship and having like a meaningful intervention and understanding for this person. That is the end of my presentation. Does anybody have any questions?
All right. Oh, Alex, is your hand up?
Yeah.
Okay, good. I thought. Great.
Hi. Thank you for the presentation, Katie. It was super helpful. I just have a question. So how does how do the dimensions of how is client choice affected by the presence of psychosis, and how do we work with them as providers on that? So let's say someone's goal is to become like the King of England, how
Yeah.
would that look in practice?
Yeah, great question. So my first thought to your question of like how does psychosis impact someone's ability to like make effective choices is that it depends on the person. So in this case, I'm assuming that this person, like the example that you're giving is somebody whose goal is perhaps not based in reality. Like I want to help you, but you want to be something that I can't help you be. Is that right? Yeah. So then in that case, um, I have a couple of answers, and not any of them is the absolute right answer. But I want to share an example where I had been working with somebody who similarly, his goal was not reality based. He had a delusion that he believed that he was owed money by an insurance company, and that I was the one that was supposed to deliver his check to him. So he wanted me to call the insurance company to get his check. There was a lot of investigation into this because I wanted to help him. He was vulnerable. He was older adult, very cleanly dressed, like wanting to get his money, and had lost his house. So after some investigation, we checked in with fiscal. Did we have any checks for this person? Does anybody know of him? I think I tried calling the insurance company once or twice. He did not have any documentation or know of anybody's names. They also did not know anything about him. So we kind of got to the point where we pursued it to the point where then we're figuring out that this is not something we're going to be able to do. At which point then for him, I wanted to maintain that he knew that I'm here to help him, but that my ability to help him is limited to these particular categories. I can help you get housing. I can help you if you need to take a shower. I can make sure that there's a shower available to you. If you are hungry, I can get you a meal. I'm not able to help you with these checks. And then I hold space for him. He's frustrated. He's disappointed. He wants me to be able to, if I could just call them, then they'll know. If we just let them know, and so I'm standing up against that delusion because I'm not able to go forward with it, but I am still maintaining these are the ways that I can help you. If you want me to help you in these ways, I'm happy to. It did have to get to a point where he, a little bit of a firmer boundary of letting him know, I'm not able just basically reiterating, I'm not able to help you with these checks, as opposed to being like, those checks aren't real. You know what I mean? Like if you want to pursue those checks, you can do that on your own time, but you and me, we work on housing together. You know what I mean? Any other questions? Great question, Alex. Thank you.
All right, I don't see any other hands going up. You guys will have a chance at the end again to ask Katie a question, as well as our other presenters. But now I'm going to introduce our next presenter, who'll be talking about personality disorders. Nicole Anslin, who most of you know very well. She's been with the agency longer than I have and is our director of community-based programs. So I'm going to share her PowerPoint. And then I'm going to mute and give Nicole the stage.
Hello. Thanks, Allison. Appreciate that introduction. Yes, I have been with the agency now for 6 years. For care coordination, for some of you, this PowerPoint may look familiar because I have presented this to some of you already, but some of you are newer, so this is new information, but it's always also a good refresher. So I'm hoping that it is helpful to you all. So personality disorders, I wanted to get a little bit into because I do feel as though we do have a lot of clients who have that as a diagnosis, and sometimes it can be very difficult to manage. There's a lot of symptoms and feelings, and sometimes substance abuse, multiple, just kind of runs the gamut of behaviors that are not healthy, that people with personality disorders go through. So then, as you know, the direct support professional that is helping them, it could also, you know, impact your own thinking, your own biases, and really sometimes make you unsure of next steps. So again, hopefully this is helpful. Can anyone tell me what is a personality disorder? Anybody? Okay. Well, we've moved on to the screen that tells you.
So sorry, I pulled it up, but I pulled the answer up while you were on there.
No worries. But essentially, just basically during this presentation for agenda-wise, we're going to go over what is a personality disorders. There are different cluster types of personality disorders, causes, risk factors, diagnosis and treatment, and then barriers to treatment. And then, you know, essentially what you as a staff person can do to help your client in need. So personality disorder is essentially a rigid and unhealthy pattern of thinking, functioning, and behaving. There are usually, just with any mental illness, there are usually significant limitations that impact your relationships, your work, your school, things like that. In some cases, most people don't even really recognize that they have a personality disorder because their way of thinking and behaving just seems so natural to them. This is how they've sort of always navigated the world, and this is them, take it or leave it. And then when people are not understanding, and when people are sort of a little bit more confrontational about their way of thinking and behaving, they do tend to blame other people for any of their challenges. Personality disorders usually begin in teenage years or early adulthood. And then we're going to go into some of the different types. So there is cluster A, B, and C. So they are based on similar characteristics and symptoms. Many people with personality disorders also have signs and symptoms of at least one additional personality disorder. So it's not necessary to exhibit all the signs and symptoms listed for a disorder to be diagnosed. They also typically have, as I said, sometimes co-occurring other disorders. So it's not unusual to see someone, you know, with borderline personality disorder that also maybe has major depression or anxiety, things like that. So And just stop me if I'm going too fast or if you have any questions. So cluster A is the odd or eccentric type. Haven't seen this one too much in our work, honestly. My background is also been a therapist now for close to 15 years. And I've worked pretty much in every setting, mental health institutions, inpatients, substance abuse, inpatients, outpatients. So I've sort of seen a lot of different things. But this is one that I have not seen too often. This cluster A personality disorders have odd or eccentric thinking or behavior. They include paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Paranoid personality disorder is exactly what you think it is, what it sounds like. It is a pervasive distrust and suspicion of others and their motives. People with this diagnosis usually have the belief that others are trying to harm them or deceive them, or if they happen to share anything about them, that you're sort of weaponizing whatever they share. They constantly question the loyalty or trustworthiness of others. There's a hesitancy to confide in others. Perception that innocent remarks or non-threatening situations, they take those really personal as personal insults or attacks. They are typically angry or hostile reaction when they're perceived that you are giving them some sort of slight or insult. And sometimes we might see this. Sometimes, when we're out in the field and someone is going through a really difficult situation, some of us get maybe a little nervous or might smile or maybe smirk, and someone could read that as, oh, you're laughing at me, you're making fun of me, you don't really care about me. So it's always like important when you're working with clients with any mental illness, not just personality disorders, to be very aware of your own body language and your own facial expressions. They also do have a tendency to hold grudges, can be stubborn in their thinking. And then as far as the relationship with others, spouses or partners, they typically have a strong belief that their partner is unfaithful. So that is just a little bit about paranoid personality disorder. Any questions so far?
Quick question.
Sure.
Can you tell the difference between paranoid personality disorder and somebody experiencing paranoia from schizophrenia?
Great question. That would definitely come down to a clinician. Someone who could diagnose would need to evaluate that person because there is a lot of overlapping factors. Probably the biggest difference would be in relation to delusions and hallucinations. That's more so present in schizophrenia. But yes, there is something called the Diagnostic Statistical Manual. And that is something that a clinician would look at the symptoms and, sort of see what's going on here. And it makes it a lot more difficult when our clients also have other mental illness and also maybe abusing substances, because that plays a role too. And Jessica's going to get into substances next, which I think will be really helpful.
Okay, thank you.
Great question. Thanks, Jasmine. Okay, so the next one is schizoid personality disorder. This could be another one that's difficult to differentiate between schizophrenia. We do have a couple clients I could think of who we've seen this with. There's usually a lack of interest in social or personal relationships. They really prefer to be alone, sort of like lone wolves. They have a very flat affect, usually limited range of emotional expressions, an ability to take pleasure in most activities, an ability to pick up normal social cues, appearance of being cold or indifferent to others, and little or no interest in having any kind of, relationships or sexual relationships. Schizotypal is the last one in this cluster. This one is usually pretty obvious just because one of the symptoms is peculiar dress, thinking, beliefs, speech, or behavior. I have met a client with this disorder, and it is difficult to navigate because, again, they don't believe that there's anything wrong with their thinking or ways of behaving. This is just how they have always navigated life. They can also hear voices, or have odd perceptual experiences, flat emotions, inappropriate responses, social anxiety, lack of or discomfort with close relationships, usually indifferent, inappropriate, or suspicious response to others. They sometimes have magical thinking, believing that maybe they could influence people and events with their thoughts, or maybe um, like that the TV is speaking to them, or the newspaper is speaking to them, that the story, written in the news is specifically for them. And now they're on, some sort of mission with this information. So again, magical thinking, or a belief that certain casual incidents or events have hidden messages meant only for you. Again, I have had a client with this diagnosis before, and just to give you sort of like a picture of what they presented as, it was a group therapy setting, and a lot of clients have to share in group a little bit about their story, why they are there, things like that. And he would often sort of get razzed or picked on, or people would laugh because his story was so not traditional that people just couldn't believe it. So oftentimes his group mates in therapy would think that he's joking, when in reality he's very serious. These are very serious things that he's doing. So like he dressed inappropriately sometimes, like it would be summer, but he'd be in sweaters, combat boots. He always wanted to be like very different and creative with his attire. For example, he had a like lanyards that he would just have like a million keychains. It was like taking up like his whole chest because he just had so many keychains. Um, he was very extreme as far as like his beliefs. He believed that like it was his purpose to live in the woods, even though he had a home. He had a home that he owned. It was his belief to live in the woods and live with raccoons, and he had actually had to go to the doctor to get a couple different tetanus shots because he was actually attacked by raccoons that he was living with. So, he's sharing these sorts of things in groups, and people are like, laughing because they think like this guy, cannot be for real. He's joking like, oh, what a funny guy, but in reality, like this is his reality. So lots of different behaviors like that. And those are the cluster A and what they kind of look like a little bit. Cluster B, this category I feel like is the most important because I think we do see this category the most in working with our clients. Cluster B personality disorders are characterized by dramatic or emotional type. So overly emotional, unpredictable thinking or behaviors. And this includes antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. So spend a little bit more time on these ones. Antisocial personality disorder, without cheating and looking at the screen, does anyone have any clients with this that could talk about some of the characteristics that their clients experience or that they have observed? Anybody?
I had worked with somebody who would like prey on other people in the program, take their like EBT cards, and they would basically like just not have food, really exploiting people
Mhm.
and like okay with, you know what I mean, not
Yeah.
expressing any distress over it. And then also like had caused a lot of physical harm to people, and there wasn't really like any connection to the reality of that with regards to feeling remorse or, you know, understanding of the harm that had been caused.
Yeah, absolutely. Definitely. Thank you. So, like Katie said, sort of a disregard for others, their feelings, lack of empathy. Usually in childhood, they used to call it oppositional defiant disorder, something that they might have been diagnosed with in the past. They may have usually a history of incarcerations. There's usually repeated violation of rights of others, recurrent problems with the law, lying, stealing, using aliases, conning others. They could have aggressive or often violent behavior, sort of outbursts, impulsive, irresponsible, and lack of remorse or lack of empathy for others. But at the same time, they can be extremely, extremely charming. So they don't really, part of sort of, not a ruse, but part of their illness is that they really come on very friendly, very agreeable, but then when there is sort of that bump in the road, then you can sort of see the shift in different side of them. So it's definitely important when you're working with anyone with antisocial personality disorder to set strong boundaries, because they will absolutely try to cross boundaries with you. So that's a little bit on antisocial personality disorder. Um, Borderline personality disorder is another one that we see quite often. For these clients, they usually have really impulsive, risky behaviors, such as having unsafe sex, gambling, binge eating, maybe drug use. They have a very unstable or fragile self-image. Their relationships with others are often very, very intense. Their mood can be very up and down. Suicidal behavior or suicidal thoughts, threats of self-injury. That's also very common with borderline personality disorder. I've heard staff say in the past before, you know, if this person is borderline, they're saying they're going to, you know, hurt themselves, but I just don't believe them. They say this all the time. And yes, they might, but those kinds of threats should always be taken seriously, should always be investigated further and probe a little bit further. They often have an intense fear of being alone or being abandoned, ongoing feelings of emptiness, frequent intense displays of anger, and sometimes stress-related paranoia that comes and goes. Next one is histrionic personality disorder, which is pretty similar in that it clients who experience this are often really seeking a lot of attention. The one main difference I would say between borderline and histrionic personality disorder is it's usually they could be very sexually provocative to gain attention. They might speak really dramatically with strong opinions, but then have very few facts or details to actually back that up. They're easily influenced by others, shallow, rapidly changing emotions, excessive concern with physical appearance, and thinks that their relationships with others are closer than they actually are. So, you know, you may have just met them, you may have just become their care manager, and right away they're like, I love you the first day. Like, you're the best care manager, the best worker, the best housing person I've ever had. Like, everyone else is horrible, but you are just the greatest thing ever. And like overshare a lot upon maybe like your first interaction with them, things like that. So the flip side to that is it feels really nice when they're telling you you're the best ever. But the flip side is once you set that boundary or once you are unable to help them with something, because it's not within your scope, then you are the worst person ever. They've never had such a horrible worker as you before, and so on and so forth. So oftentimes that is some stress that comes along with working with those with this cluster of personality disorders. The last one is narcissistic personality disorder. Again, it's similar to the paranoid personality disorder. Sounds exactly what it is. It's a belief that you're special, more important than others, have a lot of fantasies about power, success, attractiveness, failure to recognize others' needs and feelings, an exaggeration of their achievements or talents, expectation of constant praise and admiration. There's usually an air of arrogance around them, unreasonable expectations of favors and advantages, often taking advantage of others, and envy of others or belief that others envy you. So we've also heard that before with working with clients, like, oh, you don't want to help me because you're just jealous of me, or things like that. Okay. And then the last cluster that we're going to get into is cluster C, which is anxious or fearful type. Again, we really see cluster B more often, but cluster C includes avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So avoidant personality disorder are very sensitive to criticism or rejection, lots of feelings of inadequacy, being inferior, unattractive, avoidance of work activities that require interpersonal contact or any kind of collaboration. They're socially inhibited, timid, isolated, avoiding new activities or meeting strangers. It's an extreme shyness in social situations, fear of disapproval, embarrassment, or ridicule. So, like we might see that too, where maybe someone who we're working with has this, and we're trying to get them to maybe be more social, but we really need to understand where they're coming from and meeting them where they're at. Maybe we're trying to push Compeer or Hudson House or social clubs, and they're just not ready for those, even though they crave that, they're not ready for it. Dependent personality disorder, excessive dependence on others, and feeling the need to be taken care of. They could be very submissive or clingy behaviors towards others, fear of having to provide self-care or fend for their self if left alone. There's a lot of lack of confidence, requiring excessive advice and reassurance from others to make even small decisions. So maybe we see this where, you're their worker, you're, advising them on a topic, and you're telling them one thing, but then they call your supervisor and ask the same exact question. Your supervisor gives them the same exact answer. And then maybe they call your director and they ask the same question. They just need to sort of hear it from multiple people to sort of reassure themselves and make themselves feel better. So sometimes, we might get frustrated with things like that and be like, come on, like I just gave you this answer. My supervisor is going to give you the same answer. Why are they doing this? Well, this is why. Difficulty starting or doing projects on their own, difficulty disagreeing with others, fearing disapproval, tolerance of poor or abusive treatment, even when other options are available, and an urgent need to start new relationships when one has ended. Obsessive compulsive personality disorder, that's preoccupation with details, orderliness and rules, extreme perfectionism, resulting in distress when perfection is not achieved. Desire to be in control of people, tasks, situations, inability to delegate tasks, neglect of friends, enjoyable activities because of excessive commitment to work or project, inability to discard broken or worthless objects. They typically can be rigid or very stubborn in their thinking, inflexible about morality, ethics, or values, because again, they're very rigid and in their kind of way. They don't really like to talk about, they might have a certain view on budgeting and spending their money, which sometimes we often see, especially if we're someone's payee. We would like for them to spend their money a certain way. We would like to see them budget and, go grocery shopping and do certain things. And they might want to go and spend all their money on cigarettes. There could be sort of like a back and forth about that. Obsessive compulsive personality disorder is not the same as obsessive compulsive disorder, which is a type of anxiety disorder. So I think what's really important to remember about some of these clients is that the risk factors and causes. So what we know about personality disorders is that a lot of it is biological or environmental. So where this comes from is you usually have a history of mental illness or family members with mental illness or variations in brain chemistry and structure. But environmental factors is typically the main reason where some of these illnesses may come from. So the environment in which you grew up in, the relationship with your parents or others, past traumatic events can contribute greatly towards having a personality disorder. So a lot of times these folks have had abusive, unstable, or chaotic families. And they always think that this is, they think that this is normal, that this is just how life is. They don't understand healthy dynamics. So someone recently said to me, they had a chaotic family growing up, and they had said, I didn't realize like what family looked like until I started working and until I started going in people's homes to work and clean for them. And I would see parents sit down with their kids at the table and do homework and have dinner together. And for me, I never saw that growing up. So I felt like, whoa, this is what family actually is. I always got in trouble. My parents never helped me with homework, but I was still expected to get good grades. Someone who just had a very traumatic, abusive upbringing. So sometimes I think it's important to remind ourselves, because these clients can characteristically, sometimes we use the words high needs or difficult. I think it's important to remember where some of this is coming from, and that there are people who are in pain and have a mental illness, and sort of bring it back to that when you're feeling, overwhelmed by some of their actions or attitudes and behaviors towards you, is that this job is not personal. A lot of times it is what's just happening for clients and things that they have gone through. So let's go. So for diagnosis and treatment, just briefly, I'm not going to read this whole thing to you. Diagnosis, if anyone is recognizing these symptoms in themselves, and that it's impacting work, school, social activities, relationships, they should consult their doctor, therapist, or other mental health provider. As I said, there's also the DSM-5, the revised version, and then having a psychiatric evaluation are all ways that people can be diagnosed. Treatment, there is no medications that can combat a personality disorder. However, because they are so closely correlated with having other mental health conditions such as anxiety, depression, so on, sometimes there is a need for maybe a mood stabilizer or maybe medications for anxiety or depression that might help ease some of the other symptoms that come along with a personality disorder. Sometimes we do have clients, especially ones who self-harm, who may need a hospitalization or long-term treatment facilities as needed. And then as far as treatment goes, really commitment to therapy and coping skills is what helps the most with clients with personality disorders. So CBT is a really good therapy, DBT, motivational interviewing, which is what we're talking about today. Things like that. So treatment barriers. With all of these personality disorders and all the different symptoms and things that they might go through, can anyone tell me what, without reading the screen, what some treatment barriers might be, or barriers that you yourself have come across with working with this population?
I feel like a lot of people, like especially with borderline personality disorder, they have like that relationship, interpersonal relationship issues. So trying to get them to see a therapist they might become unhealthy because they might see that person as their best friend and not like a therapist relationship, since a lot of people with that have like interpersonal relationship issues.
Yeah, absolutely. Can anybody think of anything else?
I also think it might be difficult to get that addressed too if the individual sees it as something that's like natural to them, you know? Like,
Mhm.
what's the issue? I've always been like this, you know?
Yes, absolutely.
I
Yeah,
think with their relationship with their care manager or whoever their providers are, it can also be difficult because they sometimes will go back and forth between thinking like you're the greatest thing and then thinking that you're like the worst thing ever.
definitely. Good. Okay. So yes, client does not recognize the need to change their attitudes or behaviors. Again, this is how they always navigated life. I'm doing everything great. What's wrong with you guys? They might also be, their symptoms are just, they're really elevated right now. And maybe, for example, they might be distrustful. So, they're not going to go see a therapist. They're can be set in their ways. So like, I tried therapy, it just wasn't for me. Sometimes you have to, we're all different. Sometimes we have to work with different people. So sometimes it takes multiple attempts at medications or different therapists or different groups or things like that. Personality disorders, especially borderline personality disorder, is also really highly, highly stigmatized. Um, so a lot of people believe or have a false belief that it's some sort of moral failing, that a person just has control and they could just change. And this is very logical. Why aren't they doing this? And that's just not true. So those sort of beliefs, or stigma can impact, obviously, relationship to therapy, especially if they're feeling stigmatized or judged. They don't improve, symptoms worsen, and then they just have, a negative relationship with any kind of mental health provider. Um, and because also these features of borderline personality disorder and other personality disorders are often features like being really angry, having thoughts of suicide, having these extremes like highs and lows, they could get labeled, as I said, as difficult, non-compliant, manipulative, troublemakers, unresponsible, impossible. And this can create a difficulty and challenge for providers. Um, Traits of borderline personality that lead to unstable and stormy interpersonal relationships can have the same effect on the therapeutic relationship, creating clinician difficulty in establishing rapport and alliance and resulting in early treatment termination by the clients. Because as Katie went into a little bit, we don't necessarily want to challenge clients. We are well aware that their way of thinking is not healthy and unhelpful and maybe contributing to the same problems that they continue to have. But to just go in and say, hey, this isn't working, what are you going to do differently, is not a helpful response. So really, getting to know a client, getting to build that relationship, being patient with them is going to go a lot further than sort of being combative with them. So what can you do as a care manager, other support staff to help those with this diagnosis? Again, being patient, meeting clients in whatever stage of change they're in. Again, being mindful of your tone, of voice, your inflection. Setting boundaries is extremely important for those with personality disorders. Um, Building trust, being honest and truthful, and creating a safe space, and also being non-judgmental. Listening more. Sometimes our clients just need to be heard and validated, and that's all it takes. I've had clients call me angry before about something that happened, and all it took was for me to just say, okay, like, let's talk about this. I'm here, I'm listening, tell me what's going on. And then by the time the conversation is done, they're like, okay, that was really helpful, thanks, and hang up. So sometimes you just need to be a kind ear. Also utilizing supervision to address any of your own biases. You know, we all have them. Recognizing how your own upbringing, mental health, personal beliefs, values can impact your relationship with your client, or if you're feeling overwhelmed or burnt out from a client, because that could also happen to us too. And it's important to recognize that it's not any sort of failing or anything that you have done as their worker. Sometimes we get burnt out. We need a break, and that's okay. So this was just a quote I threw in here, just again to help remember that these are people with past trauma, and even when we're frustrated, we have to remember that these people have a past and that they're in pain, and that this is what is causing this. So this quote that just says, "You're taking everything too personally because of past trauma. You're not a museum. Leave the past in the past. If it's hysterical, it's usually historical." So when our clients are having those like range of emotions where they love us one day and hate us the next, it's just important to remember that these are people who are probably in pain, and it has nothing to do with you. Be sure to practice self-care. Utilize your wellness days, PTO. We have to update this number because our EAP just recently changed this month, but utilize the EAP. Ask for help. There's no shame in asking your supervisor or anybody else for help. Go to therapy yourself. Engage with positive people in your life. Engage in positive activities you enjoy. Try yoga, meditation, going on hikes, art therapy, anything that really speaks to you personally that is a good self-care activity for you. And that's all I have. So, any questions about that?
I believe Alex has his hand up. Alex, go ahead. Alex, we can't hear you.
That may have been an error because he was opening the door for Herman.
Oh, okay. All right.
I guess structural barriers when I guess addressing treatment that some clients might experience.
What do you mean by structural barriers?
So like, I guess for example, like, let's say, again, going back to culture, let's say some communities might not feel comfortable going to a therapist because,
Mhm.
you know, they have like alternative ways, like, I don't know, through a church or something, or maybe
Right.
talking to their loved ones, you know?
Mhm.
And like, even though, you know, talking to a loved one can only get you so far with like obsessive compulsive personality disorder, right? So like, how do we take that into account when we're working with them in terms of like meeting their goals and things like that?
Yeah, it's always important to take into account someone's cultural background, someone's beliefs. It's really about just building that rapport with them, building that layer of trust, so that they feel comfortable with you, and that you can eventually get to those more difficult conversations. Like Katie said in her presentation around just building that rapport and saying like, hey, I'm here to help. These are the things that I could help you with. This is what's within my scope. This isn't, you know, and getting to sort of that, using motivational interviewing to get to like, what is their goal? What is the most important thing to them? And sort of meeting them there, because that will go a lot further than just saying like, okay, well, that's nice that you think you could just handle this by talking to family members, but actually I think, you know, you need therapy. That's not going to be met very well. Like, we should refrain from doing any sort of challenging in the beginning. We should definitely be listening a lot more in the beginning. And once we have that rapport sort of built with the client, and then we know that the client trusts us, then we can maybe start having some of those more difficult conversations. But the key piece in motivational interviewing is really finding that common ground of, okay, what is your goal and how could I help you achieve that goal? And what are maybe some things that might be getting in your way that we can work on together? Because again, like these, you know, these people have been living this way their whole entire lives. They're not just going to change overnight. We would love that. We would love to see people well and succeeding and doing the right things, but it's a journey. I hope that answers your question. Anything else?
All right. If you have any other questions, we can ask them at the end. I'm going to introduce our third and final presenter for the day. You may know her, Jessica Amata. She's our core clinician or social worker. I'm sorry, I got your title wrong. And provides in-home therapy and therapy at Hudson House to people who are eligible for our core program. So take it away, Jessica.
Hi, everybody. How's everybody doing today? I promise this will not hurt. It's the last 20 minutes, and I know everybody wants to end their lovely week. I have Barbara here with me, being very supportive. Allison, my slides.
Do you have your, I can't let you click. Sorry if that message didn't get to you, but I can share your slides if you'd like.
No, I'll share. It's fine. I wasn't sure if you were sharing everybody else's.
No, I have to go on the back end and set up the remote option thing, I think, or I'm just not seeing it. Either are entirely possible.
Okay, hang on one second. I got it right here. But my presentation today is based on substance use. So we all know people that struggle with substance use, whether it be our clients or in our personal lives. Substance use disorders are a very wide range, and they affect millions of people in America. I'm sorry, I'm pulling this up right now. Here we go. And share screen. Here we go. Can you guys see it?
Yes.
Okay, perfect. Wait, I just have to move this. Okay, so substance use disorders, common diagnosis and diagnostic criteria. So substance use disorder, the definition in the DSM-5 is a complex condition in which there is uncontrolled use of a substance despite harmful consequences. As defined by the DSM-5 is the presence of at least 2 of 11 specific symptoms in a 12-month period. These symptoms fall into 4 categories, which is impaired control, social impairment, risky use, and pharmacological criteria. Common types are opioid use disorder, alcohol use disorder, cocaine, methamphetamine, hallucinogen, and stimulants. Opioid use disorder, which is currently the most common right now, is by definition a problematic pattern of opioid use leading to significant impairment or distress. So use of opioids in larger amounts or over a longer period than intended, persistent desire or unsuccessful efforts to cut down or control, a great deal of time spent in obtaining, using, or recovering from opioids, cravings and strong desire to use them, continued use despite social or interpersonal problems, and tolerance and withdrawal. How many of you guys have clients that you know for a fact are using opioids? Does anybody want to share what you see, what that may look like?
So for my specific client, what's going on with her is that she's kind of went into, I guess, a little more paranoid where she feels like everyone is out to get her now. So when she has her moments where she's withdrawing and she's not, obviously using, she's okay. But the moment she starts using, she feels like everybody's coming after her, everybody's trying to hurt her. So it's an up and down. And then she'll get very combative, but the moment she uses, then she kind of chills out, she relaxes. And even though I know she's using, she'll sit here and she'll be like, no, 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 I'm not, I don't really need any services right now. I'm okay. But then the next time I talk to her, like she's slurring her words and it's hard to make out sometimes what she's saying because she's so high.
Right. And I don't know if you guys ever noticed, but people that use opioids they have physical symptoms that we can see. So the nodding out, the sweating profusely. There's so many different things that they can display that you'll know if they are currently in the midst of their using. You know, they might not do it in front of you, but they can go to the bathroom. People that go to the bathroom often, especially if they have a history of substance use, you'll know what's happening. So examples of these substances, it's not only heroin, obviously there's fentanyl too. There's also a mixture out there. I've actually heard, so my background is in substance use. I worked for 4 years in all kinds of different modalities of drug programs. So I've actually heard from clients that they sell heroin or fentanyl or a mixture. So you can ask your dealer for both. And they come in little glassine bags, usually with stamps on them. And then also prescription painkillers such as oxycodone or morphine. So Narcan, you guys all, I'm sure Narcan is very popular, but I will go over it. So what are the benefits of Narcan and what is it? Narcan is the brand name for naloxone. It's a life-saving medication used to rapidly reverse opioid overdoses. It works by binding to the opioid receptors in the brain, blocking the effects of opioids like heroin, fentanyl, and prescription painkillers. Key benefits. It saves lives. Narcan can quickly restore normal breathing in someone who has overdosed, potentially preventing death. It's widely accessible, available without a prescription in many areas, and easy to use, even by people without medical training. It's non-addictive and safe. Narcan has no potential for abuse and doesn't harm individuals if administered mistakenly to someone not experiencing an overdose. These points make Narcan a crucial tool in combating the opioid epidemic. Has anybody here ever Narcaned anyone? No? Yes? So what was your experience like after they came to?
They were very confused. Didn't know how this person was sitting on the sidewalk, didn't know how they had gotten there or who I was.
Oftentimes they'd also can come back angry. What happens is that when you Narcan them, their high goes away completely and they're upset, very angry. They usually tend to say they don't want medical treatment. They don't call an ambulance, you know, they might curse you out. But just know that you saved their life. You know, and you could only suggest to get medical help. You can't force anyone to go to the hospital. But you definitely did a good thing by saving their life. So Narcan is available. I mean, there's ADAC, there's tons of resources that can give us, I mean, we have in the office. So if you guys ever, you know, need a Narcan, Carrie Connors is also a Narcan trainer of trainers. So I'm sure if you email her, you know, and set it up, she'll be happy to assist. Alcohol use disorder, one of our most common disorders, a chronic disease characterized by uncontrolled drinking and preoccupation with alcohol. So alcohol is often taken in larger amounts or over a longer period than intended. It's the persistent desire or unsuccessful efforts to cut down alcohol use, recurrent use in situations where it's physically hazardous, like driving, continued use despite having physical or psychological problems, and again, tolerance and withdrawal. It can lead to liver disease, cardiovascular problems, and increased risk of accidents. I'm sure someone knows or has seen an alcoholic. It's very difficult to watch for a loved one, and even in our clients. Alcohol and benzodiazepine dependency. So this is really important. So alcohol and benzos, which is commonly known as Xanax, Valium, Ativan, Klonopin, or Restoril, these dependencies require medical detox due to the high risk of severe withdrawal symptoms. Both substances can lead to life-threatening conditions such as seizures, delirium tremens, so that's when people shake, and respiratory failure with the benzos. Medical supervision is crucial to monitor and manage these symptoms safely, ensuring a gradual, controlled reduction of the substance to avoid complications. I once had a client that had a grand mal seizure because he was going through withdrawal, and he fell in his bathroom and hit his head and had to go to the hospital because of that. So alcohol, if you send somebody to detox, it has to be like a medically supervised detox, because if not, they won't, a regular 28-day or a long-term inpatient won't take them. Cocaine use disorder. A pattern of cocaine use leading to clinically significant impairment or distress. Taking cocaine in larger amounts for a longer period than intended, unable to reduce or control cocaine use, significant time spent obtaining, using, or recovering from cocaine effects, craving cocaine, problems with work, school, or social obligations, continued use despite interpersonal or legal problems. So if you notice that cocaine didn't have what the others have, tolerance and withdrawal, that's because cocaine does have tolerance, but there's no scientific withdrawal symptoms from cocaine. You can ask someone to go to a rehab, and they'll like, the doctors will tell you that cocaine doesn't have any withdrawal symptoms. I've actually seen clients have to drink in order to get into a detox, if it's just cocaine they're using. The consequences to cocaine use are cardiovascular problems, stroke, seizures, paranoia, and risk of overdose. So with overdose of cocaine could potentially mean like a heart attack, because your heart beats really fast. And the more you take, the more it gets worse. Methamphetamine use. It's a chronic condition where methamphetamine use leads to significant impairment or distress. Using more methamphetamine than intended, unsuccessful efforts to cut down or control, increased time spent obtaining, using, and recovering, continued use despite physical or mental health problems. So you'll see that in every diagnosis for substance use. Everyone always tries to cut down or control it. They spend significant amount of time trying to get it, trying to find money for it, and recovering from it. This one also has the cravings, the tolerance, and the withdrawal. With methamphetamine, very much like cocaine, there's extreme weight loss, dental problems, violent behavior if they don't have it, and cognitive decline. I hate this word, I'm sorry. Hallucinogen related disorders. A disorder characterized by the misuse of hallucinogenic substances like LSD, psilocybin, or PCP. Using hallucinogens in larger amounts or over a longer period than intended, unable to reduce or control use, and significant time spent using and recovering from the effects. Continued use despite knowing it's causing mental or physical harm. Consequences are flashback, psychosis, impaired perception, and long-term cognitive effects. So I've heard many stories back in like the 60s, they were using like acid and tabs and, all kinds of stuff. And you hear about Woodstock. So during the concert, everybody had like fun on these drugs. So that's kind of what they're talking about. Stimulants, a disorder where stimulant drugs like amphetamines or prescription stimulants are misused. Taking larger amounts than intended, unsuccessful attempts to quit or reduce, significant time spent using, obtaining, and recovering, failure to fulfill obligations due to stimulant use, continued use despite mental or physical harm. These consequences are anxiety, paranoia, heart problems, weight loss, and sleep disturbances. That's also, the sleep disturbances also goes for cocaine and methamphetamine. I've known some of my clients to be awake for 4 and 5 days at a time. Some common treatment approaches. So treatment for SUD varies depending on the substance, but often includes a combination of behavioral therapy, medications, and support groups. In terms of therapy, CBT is widely used for substance use treatment, contingency management, and motivational enhancement therapy. Motivational interviewing is helping the client realize for themselves what they can do, and guiding them to understanding that they know they can do this. There's also medications for it. So methadone, and there's a methadone clinic not that far from our office. buprenorphine, naltrexone, so that's Suboxone, disulfiram for alcohol. And everybody knows there's support groups like AA, NA, and Smart Recovery. And for the loved ones of people that struggle, they have Naranon and Al-Anon too, that can be very useful. So I created this and I have a rehabs list here. So there's, and I'll send you guys this if you want. I have a list of detoxes, 28 days, long terms, and outpatients, and all in Orange County and in the surrounding counties. So the key takeaway is substance use disorders are serious conditions that require comprehensive treatment approaches, early diagnosis, and intervention improve outcomes. Seek treatment options or refer to mental health professionals for further support. Again, you can't force someone to go to treatment, but you can encourage it, make suggestions, and just be very supportive. And like Nicole said, with the personality disorders, just be supportive. Right now, we're practicing a lot of harm reduction. That's why there's MAT, suggestions like methadone, Suboxone are very, very good in keeping people from, even committing crimes to get their drugs. The key is to keep them alive. Do you guys have any questions? Yes, Alex.
Hi, Jessica. Thank you for this presentation. I think it was super necessary, especially considering since, we're seeing a resurgence of kind of tolerance towards mental health, but I feel like, I don't know, from my perspective, the same isn't granted towards people that use substances. I feel like it's a little more stigmatized than, having a mental health condition, even if a lot of people use it as a way to cope. But in your professional opinion, do you think that substance use is, I guess, more stigmatized than, I guess, other conditions or issues?
Absolutely, 100%. So the great debate, when I came into the field, the great debate was, what do you treat first, mental illness or substance use? Because 99% of the clients that need substance abuse treatment have a mental health disorder too. So ideally, you would get rid of the substance first so they can work on their mental illness. Anybody else? So I left off with 5 minutes. Does anybody have anything they want to share? An experience, anything? Any questions at all about treatment, how it works? Well, thank you guys for letting me share.
Yes, thank you all for coming today on this Friday afternoon. It is gorgeous outside. I can see through my window. Oh, Jessica, I just saw the high five. Great job to all three of our presenters. I know you guys do a lot of talking one-on-one with people, but talking on Zoom to so many at once can certainly be intimidating. So thank you to Katie, Nicole, and Jessica for sharing. If you guys do come up with questions, I'm sure you can email them. They're in our email directory, just the first initial and last name. And also, we're going to be coming together, and I hope to see all of you and maybe some more of your colleagues in part 2, which is on October 10th. Same time, not the same Zoom, but you should have it in your calendar already, different Zoom. So we can always start off next session with some questions. I did see some people that asked for the PowerPoints and also the resources. So I'm going to be making a resource list out of the resources provided in the 3 PowerPoints. And then I'll also be emailing out to all users on Monday the resources available as well. So you guys can access those easily. All right. Well, everybody enjoy your weekend. Happy Friday. And we got you out of here before 4 o'clock. I'm so happy. All right. Thanks, guys.
Thank you. You too. Bye.
Thank you.
Thank you.
I really